So the only way to change these numbers is by increasing awareness. Breast cancer is a treatable disease and chances of survival are higher if it is detected in time. So what are the diagnostic modalities available for diagnosing breast problems? Mammograms, ultrasound, digital breast tomosynthesis, MRI, FNAC/core biopsy, galactography, and contrast-enhanced mammography. Understanding the spectrum of normal appearances across different imaging modalities enables accurate interpretation of the imaging and pathologic finding in this region. Correlation with patient symptoms is key to interpreting the imaging findings, identifying the underlying disease, and guiding the further management. Let us begin with the basic unit of the breast lobule, responsible for breast milk production. Several of these lobules constitute a lobe, and from these lobes, there are lactiferous ducts which drain at least 15 to 20 lobes of a mammary gland. In the subaerial regions, these ducts converge and expand to form lactiferous sinus. The ducts then drain through 9 to 20 orifices in the nipple around the area of the Montgomery glands, which are modified sebaceous glands and help to replicate the areola during lactation. The skin of the nipple areolar complex is hyperpigmented here. Hyperpigmented squamous epithelium, and it includes sweat glands, sebaceous gland, hair follicles, smooth muscles. And it has got a good subareolar lymphatic plexus. So whatever diseases are there in the nipple areolar complex, they will have a higher lymphatic spread. Now coming to the mammogram, so you should understand how to see the mammograms, how to report them, and what is the lexicon which we are recently following. So any breast mammogram, when it comes to you, you are supposed to see what is the composition of the breast. First, whether it is entirely fatty, that will be composition B. Second is with the scattered areas of fibroglandular density, that is B. Then heterogeneously dense, which may obscure mass, that is C. And extremely dense, which lowers the sensitivity. Then whatever mass you are getting on it, it has to be described according to the shape, margin, and density. Shape, oval, round, irregular. Margins, whether the lesions are circumscribed, obscured, microlobulated, indistinct, spiculated. Then density, fat, low, equal, high. Then asymmetry. Asymmetry, if it is only on one, then it is asymmetry. Focal, if it is on both the views. Global, which involves a segment. And developing. Developing is which was not there on the prior mammograms and it came on mammogram, which you have done now. If you have a prior mammogram, please always compare with that mammogram. Comparison is very necessary to find out the initial stages of cancer. Architectural distortion, that is distorted parenchyma with no visible mass. Calcifications. Calcifications can be typically benign or suspicious. Calcifications are quantified by two things, morphology and distribution. So morphology is typically benign and suspicious. This we will discuss in detail because on mammogram, the main purpose of mammogram is most of the time to see what are the calcifications. So
Dr. Singh, sorry to interrupt.
Suspicious is amorphous, coarse, heterogeneous, fine pleomorphic.
Your voice is breaking in between. Is there an internet issue at your end?
Now is it okay?
Yeah, it's better, but it just gets distorted in between. I mean.
Okay, I will see that.
Yeah.
So the suspicious is fine pleomorphic, fine linear, branch. Then comes reason in one of the segments, one of the area grouped just study within a 1 centimeter of range or 2 centimeter of a range according to the recent criteria. Then linear, that is a ductal distribution, and segmental, in which it is again following the ductal distribution. Associated features, skin retraction, that is nipple retraction, skin thickening, trabecular thickening, axillary retinopathy, architectural.
We lost you again.
And calcifications. Are you able to hear it now? See,
no. Is there anyone else using the same internet or the bandwidth is less?
Just a second. I will see to that. Just give me 1 minute for that.
Yeah.
I hope now it should be okay.
Yeah, as of now, it sounds great. Yeah.
Yeah, okay. So we were discussing calcifications. Yeah, benign calcifications, they could be skin, vascular, rim, dystrophic, milk of calcium, popcorn, suture, and large rod-like. So you can appreciate these are the skin calcifications. Then you have vascular calcifications, rim-like, dystrophic when there is some history of prior surgery. Then milk of calcium. Milk of calcium is they will have the change in shape when you're doing amylo or CC views. Then you have popcorn calcifications, large rod-like calcifications, and then you have punctate calcifications. What are the suspicious calcifications? Suspicious calcifications are amorphous, coarse heterogeneous, fine pleomorphic, fine linear branching. So this is fine linear branching. These are pleomorphic. Amorphous, you cannot make them out the shape very well, but you know that some calcification is there. And then these are coarse and heterogeneous. So if you see the calcifications, if you divide them by the morphology and the distribution, morphology you can have typically benign, then borderline, then typically suspicious. Again, distribution also typically benign if it is diffuse, borderline if it is grouped or regional, and then typically suspicious if it is linear or segmental. Coming to the mammographic lexicon. Mammographic lexicon, again, if we are seeing this classification with the help of both morphology and distribution, then in the end, you will have 4 types of calcification. First is typically benign, then typically suspicious by Barrett's 4B or C, which includes amorphous, coarse, or heterogeneous calcifications. Then new, fine, linear branching microcalcifications in segmental distribution. If you get this, this is directly Barrett's 5. Then what is the left group is grouped calcifications, which are in punctate distribution, that is Barrett's 3. Coming to the ultrasound. Ultrasound, again, you are supposed to classify the breast parenchyma, whether it is homogeneous or homogeneous with fibrogranular content and heterogeneous. And if you get a mass, then again the mass has to be classified according to the shape, margin, orientation, echo pattern, and posterior features. If you get any mass, you're supposed to see whether it is oval, round, or irregular. Then margins, circumscribed or non-circumscribed. Orientation, parallel or not parallel. Parallel is along the axial plane of the breast. Okay, then not parallel. The echo pattern, anechoic, hyperechoic, complex, cystic, solid, hyperechoic, isoechoic, heterogeneous. Posterior features, that there are no features, enhancement, shadowing, or combined pattern is there. Then look at the calcifications. You won't be picking up the micro calcifications on ultrasound, but obviously the coarse calcifications, people would be able to pick it up. So in mass, outside mass, intraductal. Then associated features, architecture distortion, duct changes, skin thickening, skin retraction, edema, vascularity, and the elasticity, if you have elastography available with your ultrasound machine. The special cases, which include simple cells, clustered microcells, complicated cells, mass in or on the skin, foreign body, and other things. So this is what we are doing at the mammography and ultrasound, because any patient comes with anything, these are the first 2 modalities for their assessment. So with what all complaints the patient comes to us? Patient comes to us for mastalgia, palpable breast or axillary lump, nipple discharge, nipple retraction or inversion, and non-palpable lumps. So non-palpable lumps are the lumps which are diagnosed on the routine health checkup as asymmetry on mammograms, pre-transplant checkup, evaluation of occult primary. So whenever the patient comes to you, first thing is clinical features. Second is history. Take a family history, especially on the maternal line if they have any history of breast cancer. Then personal history, smoking, radiation exposure, medical history. Go to the clinician notes, queries, or probable diagnosis which your clinician has referred with you. Examination. Already the patient has been examined by the clinician, but if you are doing an ultrasound, please do a repeat examination on your own. Then correlation of the radiological findings which you get on mammography or ultrasound, whatever you are doing with the patient's symptoms, whether they are correlating or not correlating. If not correlating or you are not able to diagnose it, then what next should be done? If diagnosed, then what has to be done? Either a follow-up or a surgical or an oncological preference. Then coming to the mastalgia. Mastalgia is the most common breast symptom experienced for almost half of the primary caregivers encountering a breast-related complaint. Exceedingly common reason for women to undergo diagnostic imaging workup, typically including ultrasound with or without preceding mammography. And the evaluation depends upon the age. Mammography if more than 40 years, ultrasound if less than 30 years. In between 30 to 40, both are recommended. Mammography should be avoided in lactating and highly painful breasts, which precludes adequate compression during mammography. However, first of all, again with 30 to 40, I would prefer to go for an ultrasound and if needed, then a mammography. Risk of malignancy in patients with breast pain. Breast pain without any other suspicious system is rarely, if ever, associated with cancer. The risk of malignancy depends upon the type of pain experience. There are two types of pain, cyclical, which are associated with the menstrual cycle, diffuse pain, not known to correlate with the presence of breast cancer. Non-cyclical pain has been found to have a low risk. And there is absolutely no role of MRI in evaluating patient with breast pain. So if the patient comes to you for the breast massalgia, you have done an ultrasound or you have done a mammogram, you know, okay, some findings you did get. But finally, what are we helping the patient with? Whether the imaging, what we are doing in the work of a breast pain is appropriate or not. And that if imaging we found anything, how likely it is that malignancy will be found. How well do the various imaging modalities perform in the evaluation of breast pain? And how effective is imaging in detecting treatable causes of pain? Finally, is a normal result helpful in reassuring patient even if she is having a pain and she comes to tell you, okay, everything is normal, whether it is really helpful or not. So for all these things, we have come with an ACR appropriateness criteria of breast pain. But before we go through this, I would like you to go through these two types of pain, clinically insignificant pain and clinically significant pain. Again, clinically insignificant is that cyclical pain, non-focal, diffuse, unilateral, bilateral, not associated with any malignancy. And these are the various causes. You can go through the table. Benign causes, hormonal variation, larger cup size, fibromyalgia, cyst, parietal mastitis, fat necrosis, surgery, Monders, and these things. Clinically significant pain, while still overwhelmingly due to a benign etiology, has occasionally been found to be associated with malignancy. When malignancy-related pain tends to be well localized and persistent. Therefore, breast pain is considered potentially clinically significant when it is persistent and is focal. So ACR has come up with the revised criteria for evaluation of breast pain in 2018. So for the females who have clinically insignificant breast pain that is non-focal, greater than 1 quadrant, diffuse or cyclic, without any other suspicious clinical then any age, initial imaging, nothing is recommended. But it doesn't happen if a female comes with the breast pain, you are supposed to do an ultrasound. Most of the time, your clinician will ask, okay, no, please do one ultrasound, even though it is not recommended. Second variant is female with clinically significant breast pain, focal, non-cyclical, age less than 30, initial imaging, obviously ultrasound. Third variant is female with clinically significant breast pain that is either focal or non-cyclical. Age is 30 to 39. On initial imaging, what all should be done? 30 to 39, you can do an ultrasound, you can do a mammography, and you can do diagnostic digital breast tomosynthesis also. And if the age is more than 40 with clinical significant pain, then obviously, again, these three are there. Ultrasound doesn't have a radiation exposure. Mammography and digital breast tomosynthesis, both of them will have a radiation exposure. Before you go for these things, you can explain to the patient what has to be done. For more than 40, I will always prefer to go do a mammography first. And for less than 40, I will always prefer to do an ultrasound first. The most common cause of massalgia is mastitis. Mastitis is just one or two slides about this. Infectious, non-infectious, malignant. Infectious, you can have simple mastitis, complicated mastitis, specific that tubercular and fungal one. Non-infectious, periductal, plasma cell, granulomatous, diabetic, post-irradiation, secondary mastitis, secondary to vascular disease, collagen disorders, foreign bodies, post-traumatic fat necrosis. And then malignant, inflammatory carcinoma or malignant abscess. This is the new proposed classification for mastitis. What is mastitis? Acute mastitis will present as a focal breast pain. Inflammatory skin changes would also be there along with the fever and malaise. It could be lactational or non-lactational. It is diagnosed clinically and managed conservatively with antibiotics. Imaging is recommended only if it is non-resolving or progressive. Again, ultrasound is the modality of choice. If it is liquefied, abscess formation is there, go for a surgical or ultrasound-guided drainage. Once or repeated aspiration with a large bore needle is recommended. If it is a large recurring abscess, then you can go for indwelling catheter drainage. Follow-up with mammography and ultrasound is recommended in non-lactational mastitis or abscess after the acute symptoms have resolved. Because if it is non-lactational, then there must be some underlying cause. You are supposed to go have a look at that again. So once this is resolved, please ask the patient to come for a follow-up. A non-resolving lesion should be subjected to biopsy. If an inflammatory breast cancer is suspected, ultrasound of both breasts and if possible, mammography. For a focal lesion, do a MAGE-guided biopsy. For a non-focal lesion, go for a contrast-enhanced MRI. Second most common mastitis, what we get is periductal mastitis. It happens typically in premenopausal. When the ducts beneath the nipple, they become inflamed, infective, and suppurative. It is a suppurative inflammatory condition. The clinical feature patient would be having tenderness, serous or sanguineous nipple discharge, then infection involving the ducts around the nipple or an inverted nipple. If it is not treated, retroareolar abscesses will happen. The smoking and nipple rings are independent risk factors for periductal mastitis. If you are doing a mammography, patient can have a normal appearance, anterior skin thickening would be there, dilated ducts can be visible, or a visible mass or focal asymmetry. On ultrasound, it will be a dilated duct with increased surrounding vascularity, then increased surrounding echogenicity and edema, then subareolar or areolar skin collections if abscess formation. On MRI, enhancement of the duct wall, and if there is a focal enhancement adjacent to the duct, dilated duct, a biopsy is always recommended to exclude adjacent malignancy. Only duct, no issues. Enhancement of duct wall, that is also okay. But if you have enhancement adjacent to it, please go for a biopsy. So these are the measures of periductal mastitis, ultrasound. Third common cause of mastalgia would be breast abscess. Again, that mastitis which was not treated became into breast abscess. So causes are same. Fistulous tract can form with the abscess ruptures to the skin. Use unlikely lactational abscesses, non-peripheral abscesses affect patient of a wider range and recur more frequently. Okay, so these things. Symptoms, swelling, pain, pus, skin warmth, nipple discharge, lump, fever. Mammogram, again, mass with obscure and distinct margins. Normally, you're not supposed to do a mammogram in these patients because they will be very painful for them. So do an ultrasound, that will be a better option. Complex solid cystic mass, heterogeneous hypoechoic mass, non-mass, all those things would be there. The clinical and imaging presentations can mimic those of an inflammatory breast cancer, which should be carefully excluded. There is another entity which is known as recurrent subareolar abscesses, also known as squamous metaplasia of lactiferous duct, which is relatively common. Inappropriate management of these abscesses can lead to prolonged disease and disfigurement. So complete surgical excision is recommended for it. So these are the few of the pictures for breast abscess which we had this is mammogram, craniocaudal view, and this you have MLO view, sorry. So this you have T2 palpable retroviral lump in the right breast, which was done on ultrasound. We got this. Then T2 weighted. This was the imaging. And on post-contrast, this is what we got, cystic lesion, which has enhancement on post-contrast image. Next most common complaint, first was mastalgia. We saw what we are supposed to do it, the common causes for it. Next is breast lump. A breast lump, what it is? A palpable breast mass. Either the patient self-detected it or it was found on clinical breast examination. Most of them are ultimately benign, but obviously if your patient gets a lump, unless it is an cause for anxiety for the patient, and patient can come again and again to you for clinical or imaging evaluation and ask, most of the patients can ask for the surgery, so please take it out. They are so afraid of the breast cancer. Those who are educated, those who know about it, they are afraid. Those who don't know, then for them, it is the main problem, what to do for them. So that is what screening should be done at all the centers, whatever, if you can just promote it in your vicinity, in your surroundings, to ask females to go for a screening. It is the most common symptom associated with the breast cancer, even though most of the causes of breast lumps are benign, but it is the most common symptom associated with breast cancer. Okay, so what is the appropriate management when the woman presents to an imaging department with a palpable breast abnormality? So triple assessment is the guideline, clinical breast examination, imaging, pathology. However, if on clinical breast examination and imaging, you are 100% sure that this is benign, biopsy can be avoided. When patient comes to you, take a history, symptoms, time of onset, fluctuation associated with menstrual cycle, recent trauma, nipple discharge, pain, fever, erythema. Risk assessment, that is family or personal history of breast cancer, any genetic mutations, pathological reports, and history of radiation exposure. Physical examination, masses which are suggestive of malignancy are most likely firm, immobile, fixed to the surrounding breast tissue. Benign, they are mobile, have a smooth, well-defined margins. Normal structures which can be mistaken for a breast mass include a prominent rib, costochondral junction, prominent fat lobule, discrete ridge of normal fibroglandular tissue, mostly in the upper quadrant, outer upper quadrant. So coming to the imaging workup, again, those two things, mammography more than 40, ultrasound less than 30, about 30 to 40, mammography and ultrasounds, both are recommended. In 30 to 40 age group, clinical correlation is advised before requesting or performing a mammogram. Example, a 32-year lady who presents with a lump that she can feel on clinical examination or a doctor has felt it. But the doctor interprets it as a normal nodular feel of the breast with a normal ultrasound, then no need of mammogram. But if you find something, okay, something might be there, then please go for a mammogram. Then next is dynamic contrast enhanced magnetic MRI of the breast is considered only if ultrasound and mammogram are inconclusive, but you are that you're the clinician or you are sure that, okay, some mass is there. So you're supposed to go in MRI. But if you are able to identify that mass on ultrasound and MR, then MRI is not needed. You can directly go with the biopsy and proceed further if you think it is something malignancy. Whenever you are doing a mammography, please put a radiopaque marker at the site of clinical concern. If the patient had recent mammogram within less than 6 months, then do mammography only for the breast in which the mass is there. In addition to CC and MLO views, breast mammographic view of the affected breast should include spot compression, magnification at the site of clinical concern. If mammography reveals a clinical clearly benign cause, such as calcified involuting fibroadenoma, lymph node, lipoma, hematomas, and all those things, no further imaging is. For all other things with probably benign or suspicious features, further evaluation with targeted ultrasound is indicated. Normal mammographic findings are not sufficient to rule out malignancy in a non-fatty breast. So if you have a female with non-fatty breast screening you are doing, please do advise them ultrasound correlation if they are suspicious. If there is no mammographic finding at the site of palpable lump, further workup with targeted ultrasound is also required. Ultrasound, palpable lumps, then obviously come with the clear benign findings such as simple cyst, lymph node, lipoma, sebaceous cyst. Nothing, just a short interval follow-up. Anything else you're getting, do a needle biopsy, aspiration or a biopsy. When both are negative in the evaluation of palpable breast mass, the negative predictive value is high, that is ranging from 97 to 100%. If combined your imaging findings and the clinical breast examination, both are not highly suspicious, patient may be reassured and advised for a clinical follow-up. MRI. Coming to MRI, MRI is not an appropriate imaging technique for evaluation of palpable symptoms because it provides little added information to careful evaluation with mammogram and ultrasound. So it obviously depends upon the technician, upon the doctor who is doing it. Biopsy would likely have been performed regardless of the MRI findings. If you find something abnormal, obviously you will go for a biopsy, whether you are doing an MRI or not. An MRI may also result in additional unnecessary biopsies due to false positive findings in area distinct from the site of initial clinical concern. So until unless you have really something doubtful which you want to confirm with MRI before the biopsy, then only go for it. But if on ultrasound and mammography only you are clear, okay, this is 100% benign or this is 100% malignant, please directly go with the biopsy. So what all the breast lumps you can have? Categories: breast lump, Barrett's 2, simple cyst, nothing has to be done. Barrett's 2/3, complicated cyst, no further imaging is required, just do a follow-up ultrasound in 6 months' time. Then cyst with a suspicious solid component, that becomes Barrett's 4. So in this, image-guided aspiration or core biopsy is advised. Then solid defined, definitely benign mass, again Barrett's 2, nothing has to be done. Solid, probably benign mass, Barrett's 3, which you're giving. Do an imaging follow-up. Otherwise, in a high-risk factor or clinical scenario, you can always go for a core biopsy also. Suspicious mass, Barrett's 4 or 5, always image-guided core biopsy. Breast lump, if you're getting only calcifications on mammogram, benign, no further evaluation. Everything which you get on calcification which you get on mammogram, core biopsy has to be done. Biopsy result, if it is a Barrett's 4 lesion, biopsy has, if it comes benign, then nothing, follow up after 6 months. That is 4A lesion. If it is malignant, then appropriate treatment. If it is inconclusive, that you don't know whether it is equivocal or ATP only, then please do a rebiopsy, preferably vacuum-assisted biopsy is recommended. Then Barrett's 5 lesion, rebiopsy is must. If you are Barrett's 5 on your mammogram or ultrasound and the biopsy has come normal, then do a rebiopsy if histopathology is negative. Okay, so again a rebiopsy is required if you are sure on mammography and ultrasound that this is Barrett's 5. Mass on clinical breast examination but negative imaging, then do a palpation guided biopsy if indicated clinically. No mass on examination as well as on imaging, then nothing further is needed. You can just ask the patient to come again for a follow-up. If the female is pregnant or lactating, go for an ultrasound first. Mass identified, give Barrett's. If suspicious or equivocal, mammography can be considered during pregnancy or lactation also. There are studies which they say that there's no such high risk. You can go for a mammography if it is indicated on ultrasound, because obviously mammogram is much better at detecting calcifications and subtle architectural distortions. CMRI of breast is not recommended during pregnancy or in a lactating female until it's absolutely indicated. Fibroadenoma, these are the one of the most common causes for the palpable breast mass, which comes to mammogram. You'll get oval, circumscribed, isodense mass, then lactating adenomas, calcifications. Older postmenopausal, you can have tubular adenomas. They mimic like this with microcalcification, which may resemble malignancy. On ultrasound, most common, this is the most common thing which you get on your ultrasound: homogeneous, hypoechoic, hypovascular, with variable post-acoustic features. So in this, these all things, okay, what are suspicious is if you get an irregular shape, non-circumscribed margins, which includes microlobulated, indistinct, angular, or spiculated margins. Even like if it is multilobulated, like people consider less than 3 to 4 lobules, that is okay. But if it is more than that, again, it is a suspicious lesion. Then a small cystic internal components, microcalcification. These are all suspicious. Hyalinized, heterogeneous, they would be heterogeneous due to degenerative changes and post-acute stemming from calcifications. Then cellular juvenile, lot of vascularity would be there. Otherwise, normally they're hypovascular, but in this, it will be highly vascular. Then coming to the lactational, they come as complex cystic and solid mass with or without irregular margins. On MRI, what do you get on fibroadenoma is variable T1, predominantly hyper T2, some homo or heterogeneous enhancement. 50% of them will be having non-enhancing internal septa, which is very characteristic for it. Coming to this myxoid fibroadenomas, they can have overlapping MRI features with those of mucinous carcinoma, having rapid enhancement, washout kinetics similar to malignancy. So make sure you go through your basic images, that is T1, T2, then everything, and then you come to the contrast. So this will be less likely you are about to miss it. So this is what you get a fibroadenoma on mammogram, and this is a fibroadenoma on ultrasound. Phyllodes tumor, this is not a very common cause of breast mass, but it does come. So just the slide on it, it occurs mostly in older females, larger mass, irregular, increasing aggressiveness. Classified, it can be benign, it can be borderline, it can be malignant. All three, it can be all three. Mammogram, again, large size, lobulated mass. Ultrasound, large, irregular shape. MRI, only limited utility is there. That surrounding breast camera can also have high signal intensity. Reflecting edema was significantly more frequent. So this was the phyllodes tumor, which we got at our place. These are the calcifications, and this was the ultrasound appearance of it. Third most common, first we had mastalgia, then breast lump, then this is nipple discharge. This is the third most common complaint for the females complaints. It is presenting feature in carcinoma breast in 5 to 12% of females. There is, what happens is basically excess secretions, they are coming in the ducts because something is obstructing the duct. So they are not able to drain. So if they are not able to drain, they will come out through the nipple. So some obstruction has to be there. That's why the patient is having nipple discharge. Unless obviously the patient is having hyperprolactinemia and all those things. So in that you can get. So evaluation is again clinical assessment, history, examination findings. Then discharge are of two types: physiological discharge and pathological. Physiological is galactoria. That is what I told you, hyperprolactinemia, you will have it. Non-spontaneous, bilateral, intermittent, long-standing, arises from multiple ducts, characteristically green, yellow, and milky. Pathological, unilateral, spontaneous, serous or bloody, which arises from a single duct, can be associated with a lump and more than 50 years of age. The cancer rate in pathological nipple discharge patients can vary from 3 to 33%. So for these patients, a proper follow-up and a proper workup is needed. Diagnostic breast imaging evaluation is not necessary for patients with clinical features of physiological discharge, but is required for patients with suspicious discharge. First investigation of choice is mammogram more than 40, ultrasound less than 30, and 30 to 40 again, first ultrasound if needed, followed by mammogram. Mammogram has a low sensitivity in cases of nipple discharge and positive predictive value, especially in dense breast. Ultrasound has higher sensitivity but lower specificity. MRIs has a very higher sensitivity and specificity. So for this is one thing which you can go for an MRI, but obviously never directly. MRI is never the first choice modality of choice. Historically, galactography was also being done. However, it yields incomplete results. Only 10 to 15% of cases you will get, and it cannot reliably exclude malignancy. So first of all, ultrasound. Any nipple discharge, do an ultrasound. Good attention to the subaerial lesion. Either you do a peripheral breast compression, move your probe in that, press it and then release it, press it and then release it, or that is known as rolled nipple, or use a standoff pad of gel. Okay, if abnormal, further management again depends on what you got, what bilates you are giving on your ultrasound. If no abnormality and discharge is serous or bloody, then please see MRI. When imaging findings, including those of MRI, are negative, then what to do? Patient is having nipple discharge, which you think it is pathological, but everything came out to negative. Then we can go for galactography, which may localize intraductal lesions and may aid in surgery, surgery in patients with pathological nipple discharge. Okay, so patients who undergo galactography guided surgery are significantly more likely to have a specific lesion, okay, rather than those who just undergo a central duct excision. And one other thing which was being done was nipple smear cytology, but it is not used as a diagnostic method, and it has been recently proven into multiple studies that it has a limited diagnostic accuracy. Most common cause of nipple discharge is papilloma. It is a high risk lesion. Surgical excision has to be done rather than if you are confirmed on imaging, then directly go for a surgical excision. You no need to do a image guided biopsy. If clinical imaging features are ductectasia, peritoneal mastitis, then again culture sensitive the duct discharge can be done and antibiotic treatment. And if clinical breast examination and imaging are negative, discharge is persistent, go for a surgical exploration. If you think the discharge is significant, it is pathological, please go for a surgical exploration. This is the fifth common, that is nipple retraction or inversion. Although nipple retraction and nipple inversion are frequently used, but they are distinct entities. Nipple retraction is asymmetric, it is acquired. Okay, nipple inversion is which was symmetric and it is physiological. However, inverted nipple may be congenital or secondary acquired due to benign or malignant process. But most of the time, if you are having it as symmetrical or by birth, or it's like ever since the female had it, you try to say it as an inversion. Whereas retraction is when it happens secondary. Acquired nipple inversion develops after puberty or breast development. Okay. So both they can have benign or malignant causes. We will discussing the malignant causes for this nipple retraction: traumatic fat necrosis, Mondor's disease, infectious process, several papillomatosis, ductal ectasia, weight loss, breast surgery, breast cancer. Then this was the fifth thing which you get for the patients who come to you: non-palpable breast lesion. Nothing was there, but it was found during a screening mammogram or some other pathology, or patient was getting evaluated from some malignancy, evaluation of focal primary breast malignancy, or incidental finding on CT or PET. Then what to do for these lesions? First of all, what is our job in this? Non-papillary breast, first of all, detect it. If you can diagnose it on ultrasound mammogram, very good, interpret it. Initial recommendation, once you are diagnosed it, what it is, then depending upon the barriers, tell whether to come for a screening follow-up, return to the routine screen that is just something benign, you can go to the routine, or you need a further evaluation or a simple follow-up is needed. Then risk estimation of these lesions, clinical examination, and if needed, pathological evaluation. And then after pathology, what it depends upon the biopsy results, what you're getting, again, recommending what to do further. So again, non-papillary breast lesions, again, then can be the three things: benign, malignant, and the B3 lesions. So what are these B3 lesions? Benign and malignant, the things which you already know. What to do about the B3? B3 are the high-risk lesions or lesions with uncertain malignant potential. Incidence of cancer in these group is high. So for these B3 lesions, you should take care. We will be discussing this B3 lesions later on. Imaging characteristics of the non-palpable breast, again, mammographic, see for microcalcifications, asymmetry, masses, or architectural distortion. Ultrasound, solid, cystic, margin characterization, orientation, shadowing, vascularity, elastography. MR features morphology, enhancement pattern, kinetic curve, diffusion, restriction. Then coming over to the few common breast pathologies: fibrocystic breast changes after fibroadenoma. This is the second thing, most common thing which comes to us. Age group is 20 to 40, peak before or at menopause, heterogeneous and usually dense parenchyma you will get on mammography. Few partially sequestered masses may be there. Then teacup or low density round calcifications in multiple lobes, which change position when you are seeing from CC to MLO. Okay. Ultrasound, prominent fibroglandular tissue, some small cysts could be there. These are known as SANDI. It encompasses all the changes associated with normal variations in breast parenchyma associated with changes in hormone level and aging. And thus, it is better to classify as fibrocystic changes under D. So these are the fibrocystic changes. Typically, you get a small cyst with internal septations. Septations are very thin. They are globed or clustered. Most common reason for them is outer upper quadrant. Most of the time, the female comes with the outer, and most even like if it doesn't comes for the pain, now you might not get when the patient is coming to you first time with the mastalgia. Mastalgia is the most common clinical presentation for these gens. But if you follow up that patient, might be after 6 months, you will be able to appreciate some cyst or something would be there. Then fibroadenosis. This is benign alteration in TDLU. Again, in that, the cystic appearance would be there, but you will get some solid, predominantly solid, and some component would be there. So some septations, you can make it out, okay, something is there. So mammography will show dense parenchyma, partially circumference mass, ultrasound, prominent fibroglandular tissue in the area of palpable node. Again, it is one of the Andes. Fat necrosis. Mostly it results from accidental trauma, but can happen after surgery, radiation therapy. And once symptomatic, it can present as a small, painless, ill-defined breast mass. On mammogram, lipid cysts, coarse calcifications, focal asymmetry, microcalcifications, and speculated masses. Mammography pictures reflects the amount of fibrosis in the fat necrosis. That if somewhere the necrosis is happening, obviously the surrounding tissues, some fibrosis will happen. So we'll be able to see some architectural distortion, some asymmetry, something would be there. So minimal fibrosis, radiolucent mass, or as oil cyst. Early you can get linear or curvilinear calcification. Later on, you can get central calcifications. In this, fibrosis is there, but the radiolucent fat is never completely replaced. So you might be able to appreciate that. Then atypical features would be fat fluid levels, serous hemorrhagic content, collapsed oil cyst, or oil cyst containing spherical densities. Okay. Reparative fibrotic reaction may replace all of the radiolucent necrotic fat, resulting in appearance of a focal asymmetric density. So ultrasound, solid complex mass with a mural nodule or complex mass with echogenic band, anechoic mass with post-acoustic enhancement. Margins can be well circumscribed, too indistinct, too speculated. Please make sure fat necrosis can have indistinct or speculated margins also. A mass with echogenic internal band that shifts in orientation, okay, with change in patient position, has been described as a specific sonographic indicator for fat necrosis. MRI only when you are not able to distinguish it from malignancy. Okay, then you're supposed to do it. And it can obviously mimic tumor recurrence after BCS. Calcifications will present as signal void on MRI, and fibrosis will present as architectural distortion with or without speculated margins. High, intermediate, or low signals on T1. Necrotic fat will always have low signal intensity on T1. What we are giving more emphasis because obviously half of it can mimic as a CS. So you should know how to rule out the necrotic fat. It can enhance after injection of IV paramagnetic contrast material. Enhancement could be focal, diffuse, homogeneous, heterogeneous. Enhancement depends upon the intensity of inflammatory process going on. Margins, it can be circumscribed, well-defined to speculate, just like on that ultrasound. Fat necrosis can mimic malignancy on MRI also, basis of the morphology of the contrast enhancement. So MRI may not be able to differentiate fat necrosis from malignancy because cancers and fat necrosis may enhance after administration of IV contrast material. So then final result is again needle biopsy. But biopsy may be avoided if MRI signal is similar to that of the adjacent fat on unenhanced images and the lesion shows no internal enhancement. No internal enhancement, signal is same as fat, you can just simply label as fat necrosis. But if you're getting internal enhancement, heterogeneous enhancement following the kinetics and curves of malignancy, then obviously biopsy has to be done. So these are the pictures of fat necrosis on mammography. This is how it can appear like this also. Or in this, you can appreciate some architectural distortion is there, some calcification is there, some surrounding fibrosis, and some retraction, nipple retraction is there. Or this was the case on ultrasound. On MRI, this is non-contrast, and on post-contrast, you have some peripheral enhancement. Next common cause which you get in your daily clinical practice is ductectasia, bilateral, symmetrical, subareolar ductectasia, then asymmetrical could be there. See, if we are supposed to call it as ductectasia, if it is more than 3 mm in ampullary portion and more than 2 mm in the periphery. So mammography will have dilated linear branching densities, dilated ducts. Ultrasound, it can present as benign asymmetrical ductectasia or malignant asymmetrical ductectasia. Benign is dilated ducts without any abnormality. Malignant is dilated ducts with intraluminal content, a duct wall abnormality, a solid parenchymal mass with adjacent ductal dilatation or extension. MR for ductectasia, MRI is the choice of imaging after mammography and ultrasound, but how you should do it. It's not like not needed, it is needed, but after mammogram and ultrasound. Enhancing lesion, if you get in duct wall or lumen, then only you're supposed on T1, T2, dilated increased signal intensity, branching ducts converging towards the nipple without an overlying mass. Okay. Hyperintense signals are due to thick proteinaceous fluid or blood within the ducts. So these are the ductectasia. You can appreciate these are the dilated ducts in the retroviral region. On ultrasound, these are the images. This is thick inspissated secretion. These are again dilated ducts. And this was the dilated ducts with thick inspissated secretions. One of these lesions was showing some vascularity, so we went for a CMRI for this further. Now coming to the B3 lesions. B3 lesion was one of the lesions which you get in non-palpable lump. That time we discussed B3 lesions. So B3 lesions are actually high-risk lesions, they are associated with malignancy. They can include papilloma, radial scars, atypical ductal hyperplasia, flat epithelial atypia, lobular neoplasia, fibroepithelial lesions, miscellaneous such as mucocele, spindle cells. So all B3 are supposed to be managed with surgical excision because there is uncertainty whether it will be malignant or not. Use large gauze cornidus 14-year vacuum-assisted biopsy. And all these can upgrade 5 to 20% of all these B3 lesions to overtly malignant lesions. If you are biopsy, you're doing vacuum-assisted biopsy or a large gauze cornidus 14G you're having is, then you can detect overly malignant lesions in them. Improvement in imaging techniques, image-guided interventions, and with vacuum-assisted percutaneous excision allows women to safely avoid surgical excision. VAE aims to obtain similar amount of tissue as a diagnostic surgical excision. That is 4 grams of tissue using the same method to remove the entire B3 lesion. So no significant sorry for this disturbance. Yeah. No significant difference between the rate of subsequent cancer between B3 lesions or controls at 5 years was observed. So these are slow growing malignancy, no differences there, but you should be able to make out exactly what they are. So coming to a few of the common ones, that is atypical ductal hyperplasia. One of the most commonly frequently diagnosed B3 lesion. Mammography will have clustered calcifications, ultrasound mass in defined area, MRI non-specific appearance, either mass or non-mass enhancement. Go for a contrast enhance. There will be some enhancement would be there, additional contrast. If it is high, if it gives high negative predictive value, don't go for a biopsy, just do a follow-up. And if you get something abnormal, please do a biopsy in that area. As well as it can help you diagnosing clinically unsuspected malignancies in areas which were unrelated to for this lesion for which you did it prior. National Comprehensive Cancer Network guidelines, they have given that this CMRI or contrast enhanced mammography, both of them should be considered in a female with a lifetime risk of more than 20. In several preliminary studies, MRI has shown promise as a tool to evaluate high-risk lesions to exclude the presence of coexisting malignancy with a negative predictive value between 90% and 98%. Okay. Coming to the classical lobular neoplasia, WHO has classified this as lobular carcinoma in situ or atypical lobular hyperplasia. Mammogram usually occult when microcalcifications are there. They are generally found in adjacent benign tissue, separate from it. Okay, from in the adjacent benign tissue. So you go for an MRI or contrast enhanced mammography. The characteristic finding is non-mass enhancement. Flat epithelial atypia is a B3 lesion found in 5% of the percutaneous breast biopsy that typically present on mammography as grouped amorphous calcification and on ultrasound as irregular hypoechoic mass. Then radial scar or complex sclerosing lesion. On mammogram, it will be architectural distortion, SPQ is quite long and isodence to adjacent breast parenchyma. Changes of distorted area between different mammographic views indicated of radial scar. The view will be changing on different views. Okay, the appearance will be changed. Associated microcalcifications are frequent. Ultrasound, you will have variable ranging from no clear correlate to an hypoechoic irregular mass. MRI, they can like any MRI correlate and show no enhancement, or they can present as a mass lesion. Enhancement kinetics can also be variable. Then papillary lesions, benign papilloma, sclerosing papilloma, papilloma breast, malignant papilloma with carcinoma in situ, papillary carcinoma, intraductal adenocarcinoma. Mammogram, again, dilated ducts, calcifications, suspicious microcalcifications, solitary lesions in the retroareolar area or centrally, but anywhere within, can be anywhere in the breast. Okay. Then multiple lesions are typically found in the periphery. Ultrasound, well-defined nodules with or without cystic component. MRI, papillary lesions may appear as a circumscribed enhancing mass or irregular masses with dilated ducts. Papillomas, central papillomas, peripheral papillomas, we have already discussed it. It is one of the common cause of duct dilatation and discharge. This papilloma can cause it. So spontaneous unilateral clear or bloody discharge. Mammogram usually occurred. Ultrasound, circumscribed complex solid cystic mass, intraductal mass. MRI, round or oval enhancing mass with associated high T2 signal intensity. Management is recent evidences. Surveillance may be an option for patients, specifically those without atypia. Excision for papilloma that involve atypia owing to upgrade in the disease stage at the time of surgical excision. What is papillomatosis? It is a rare entity defined by multiple intraductal papillomas that usually occur in distal duct lobular units and in younger patients. The association of papillomatosis with malignancy is still detectable with no clear imaging and follow-up guidelines. So was one patient, female with recent history of nipple inversion. We had an intraductal papilloma in this. On ultrasound, you can appreciate just a duct was seen. So on mammography, a retroidal prominent duct is seen. On ultrasound, you are able to appreciate the vascularity within the ductal solid component. Now coming to the breast cancer. Breast cancer, what you do for the imaging of the breast cancer? So first of all, whether it is coming to you for the first time, that is local extent of the first time known breast cancer. What you're supposed to do, bilateral breast, bilateral mammography and ultrasound, additional lesions, then further management depending upon the BI-RADS, not for the primary, but the additional BI-RADS to ignore or take the surgery as undertake as per plan. If it is 3, 4, 5, then do image guided biopsy for those lesions also. Preoperative contrast enhanced MRI of both breasts is not routinely recommended. However, it can be considered as per institutional policy. It is recommended in females with lobular carcinoma on histopath, young women, or with dense breast. It can be problem solving, especially if there is discrepancy in the clinically palpable extent and what the size which you're getting on mammography or ultrasound. Then you can go for it. Or ladies with breast implant, or if you are considering an accelerated partial breast irradiation. If on MRI you get an additional suspicious lesion, it can change the plan treatment and a biopsy of such lesion should be considered. This was for the breast. And for the axilla, preoperative ultrasound imaging of axilla, if clinically node negative breast, clear. If axillary node involvement is there on ultrasound, then full axillary resection during surgery has to be done instead of sentinel lymph node mapping. Abnormal lymph node detected on ultrasound will be subjected to ultrasound-guided FNAC or biopsy for confirmation if needed. Mammography or MRI are not recommended for preoperative evaluation of axilla. So, breast cancer, clinical staging, mammography, ultrasound, MRI, physical examination, CTNM, then neoadjuvant therapy, followed by surgery, pathological staging. And then what we get is after surgery, what we are doing is PTNM. So following surgery, the surgical specimen, that is tumor, sentinel nodes, axillary lymph nodes, are analyzed for pathologists, which gives us a pathological staging. After neoadjuvant therapy, the letter Y is further added to it. And based on these staging, further treatment with adjuvant chemotherapy, radiotherapy, or hormonal therapy can be decided. How to image for a patient for a response to neoadjuvant chemotherapy. So when first the chemotherapy is given and then the patient will be operated later on. So in large operable breast cancer or one with locally advanced breast cancer, these cases, you're giving neoadjuvant chemotherapy. So image-guided core biopsy with complete histological analysis, tumor grade, ER, PER, HER2 receptor status should be obtained before initiation of chemotherapy. FNAC is not sufficient. Okay, so image-guided core biopsy has to be done. And if breast conservation surgery is considered in these patients and the mass is devoid of calcifications on mammogram, please place a radiopaque marker clip in the tumor. So with the treatment, what will happen? The size will reduce. This clip will tell you to localize the tumor if in case you get a complete clinical and imaging resolution. So imaging is required to monitor the response of chemotherapy, identify non-responders early so that chemotherapy may be changed or stopped. At the end of the chemotherapy, it is required to assess the extent of residual tumor and to identify those who are likely to have achieved complete pathological response. So combination of mammography and ultrasound is the standard modality to assess response to chemotherapy. CEMRI is most accurate imaging modality, but should be used only if pre-chemotherapy good quality MRI scan is available, because you can compare. Few of the things would be because of the neoadjuvant chemotherapy. So you should have a good pre-chemotherapy MRI and then only you can do after it also. PET-CT is not recommended for assessment of response. Second is metastatic workup. If the patient is having metastasis, then early breast cancer, which are less than 5 centimeter, no axillary lymph nodes, then no occult metastasis would be there. So chest X-ray is sufficient. Additional test, if needed by the clinician, then only you're supposed to do. If the staging is T3, stage 2B of AJCC staging, then you are supposed to chest X-ray, ultrasound, abdomen, pelvis, LFT, metastatic work. Alternatively, PET-CT can also be performed, although this is not routinely advised. Image-guided biopsy of metastatic lesions is not required if imaging findings are fairly suggestive of metastasis. However, if they are equivocal, then you can go for the metastatic biopsy of the metastatic lesions also. What to do for the patients who come with metastasis from cancer of unknown primary site, that is, they present with X-ray lymph node or other lesions which show malignancy on FNAC or biopsy. So in this bilateral mammogram, ultrasound, either of them is positive, go for a biopsy. If CMR is recommended if both are normal or equivocal, but patient has unilateral X-ray lymphadenopathy and breast cancer is suspected on the FNAC or biopsy of these lymph nodes. What to do for follow-up for imaging in patients with treated breast cancer on follow-up, regular physical examination, annual mammogram, sufficient. Mammograms have always to be compared with the prior mammograms, even if these appear normal. Any suspicious or new lesion not typically benign should be subjected to biopsy. Follow-up systemic imaging to detect metastasis is not routinely recommended unless patient is asymptomatic. If metastases are detected on follow-up, its biopsy is not required if imaging findings are typically of metastasis. However, if there are new metastases, then after a long follow, then you need to do a biopsy to assess hormone receptor status of it. It is also required if the receptor status of the breast cancer was not already known. So BIRADS, after doing all the assessment and everything, what are the BIRADS category which we are assigning is BIRADS 0, incomplete, you need further anything, whether you need mammogram or ultrasound. Okay, BIRADS 1 is negative, symmetrical, no masses, architectural distortion or suspicious calcification. Nothing is there, totally normal, BIRADS 1. Benign, which you're 100% sure it is benign. BIRADS 3 is probably benign, less than 2% chances of malignancy. A short interval follow-up is recommended, or if the patient is highly anxious or something, even a biopsy, FNAC can be done. BIRADS 4, suspicious for malignancy with 2 to 95% of probability of malignancy. In this, you have BIRADS 4A, B, and C. A is low suspicion, B is moderate, and C is high suspicion. For this, biopsy has to be done. BIRADS 5, you are highly suspicious of malignancy, that is more than 95%. And 6, if it is known biopsy proven, already known case of biopsy proven malignancy. So this is what will finally happen. Once you have given your BIRADS, you have seen the patient, ultrasound mammography has been done up, now the treatment has also been done up, and now you are doing a follow-up. So both the ACR and Society for Breast Imaging recommended that breast imaging education within the residency and fellowship program should be designed to require the use of BIRADS terminology, assessment categories, and management recommendations. Basically, with your BIRADS, the management also has to be decided. So you should know exactly what will happen to the BIRADS. So if it is intramural lymph node, typically benign, implants, arterial distortion, fat cutting, these are a spectrum of benign findings, management, just routine mammography. If you get a BIRADS 3 lesion, initial recommendation, 6 months follow-up, then 12 months follow-up, then 24 months follow-up. If it disappears or becomes apparently benign before the 2-year follow-up, before the 2-year, remember that 2-year duration has to be there, it has been just right. It is assigned as BIRADS 2. However, if the lesion increases in size, that is more than 20% in diameter during follow-up, update it to the category of BIRADS 4 and recommend biopsy. This increase in size applies to masses like fibroadenomas also. If they are increasing more than 20%, then advise a biopsy for it. So that's it. I'm almost done. So this was our table, just few cases I would like to go through. If you remember, this was our table for the mammography lexicon. So these are the cases we use. You can appreciate this lesion and this lesion and this area. So this area is totally abnormal. These are our speculated margins, some dense breast parenchyma, these are the speculations. So what you will like to give it as, you can give it as BIRADS 4C. 4C, it will be good. Patient will be going for a biopsy. Then again, this lesion, there was skin thickening, retraction also, speculated margins. So this is again your BIRADS 4C lesion. 5, we are using only if we have pleomorphic or new fine linear calcifications in abnormal distribution. Then only you're supposed to give BIRADS 5. Okay, remember that. Then again, this is a lesion. Typically, you have lymph nodes also in this. Then this was phylloids, which we discussed already. We got that. Then this was a lesion. Multiple lobulations are there. MR was done. So this was a diffuser restriction we got for this patient. These are my references. So thanks a lot.
Thank you, Dr.